Okay, awesome. Thank you for that introduction. Uh, I'm excited to review with all of you the positive effects of integrated behavioral health and the benefits of them all together. Hopefully y'all can see my screen okay. I'm a licensed marriage and family therapist. So you see what that means is that I'm really good at listening for 45 minutes, but talking for that long, I guess we're about to find out. So I am coming to you from St. George, Utah, where today we will be in the 60 degrees and it's just wonderful. I've heard it said that there are two types of people that live in Utah, those that live in St. George and those that wish they did. So maybe you've been down here recently. Welcome, keep on coming. We love having visitors down here in Southern Utah. So I'm excited to review kind of the positive effects of integrated behavioral health and maybe introducing the topic to some of you that don't even know what integrated behavioral health is. But before I get too far, I want to kind of just introduce the things that make me love what I do. So that first picture you see is my oldest son and one of our recent goats. We live on an acre out in Hurricane, and we just have a little homestead that we really enjoy playing on. Our current numbers are we have 10 goats, 5 of which have been born in the past 2 months. So that's always fun to have the little babies there. And then we have 16 chickens, 14 fruit trees, 2 dogs, and then 2 adorable sons that we really like to help us out on the farm chores. You see they're in their matching pajamas for Christmas because you just have to. Then of course you've got my beautiful wife and our youngest and one of our newborn baby kids. Kids, ironically, are what baby goats are called. So if I ever refer to my children, I will say kiddos. And then we went to Hawaii for Thanksgiving last year and had some fun on the lavender farm. So there you can see, this really is why I do what I do, just because I think family is so important. It's just part of what keeps me going each and every day. As a licensed marriage and family therapist, it just brings me so much joy. So I graduated from Utah State University in 2016, and I worked in a year at a private practice. And then I realized that that isn't necessarily where I wanted to be. So from there, I found a job at the family healthcare, and I've been here ever since. I'm also on the board of directors for the Utah Association for Marriage and Family Therapy, and my role is the conference chair. So it's a lot of fun to kind of help plan those annual and semi-annual conferences just to kind of bring everybody together. So my hope this afternoon to go over is to just obviously that brief introduction. What is IBH is what we call it, integrated behavioral health. How does IBH impact couples? How is IBH effective? And then I can go over a summary and any questions. Now, feel free, just because I do work better in a question answer format. If you have questions that do come up and you want to ask them, please feel free. I would be happy to answer them as they come up instead of just waiting at the end. So what is integrated behavioral health? So integrated behavioral health is essentially you're combining both medical and behavioral interventions to focus on the whole patient. So we call it blended care at each and every visit. And what happens is the BHC works as an integrated member of the medical team. Not only is it a greater impact for providers, both medical and behavioral, but it's also a greater value for the patient. So what that means is that a behavioral health consultant is any type of licensed clinician. A licensed clinician meaning mental health clinician. So we play a different role than in the traditional mental health therapist, where you're probably used to clients. You call them clients, they'll come in and they'll visit with you for 50 minutes, and then you see X amount of clients per day and week. We have a different model where we try to focus on the whole patient and recognize that every patient that is part of our facility at some point or another is going to need some type of mental health support, be for a mental health diagnosis or for some type of chronic condition that is stressful to live with. What we do as behavioral health consultants is that we assert our expertise to address the mental, emotional, and behavioral aspects of the patient's health in conjunction with their medical needs. So what we do is we address both the behavioral health, and then the medical providers will address the medical piece in the exact same visit, which is not only beneficial to the patient for their time and finances, but by combining both services, we are sending a long-term message that behavioral health and medical services are inseparable. You can't separate the mind from the body, nor the body from the mind. And so what we do at Family Healthcare is not only crucial, but essential to every single one of our patients. BHCs work alongside the medical providers in real time. So what that means is, obviously I'm in one of our, we call it a specialty or traditional therapy room, but just on the other side of that wall is where we have all of our medical and behavioral health staff working. And truthfully, we are shoulder to shoulder. So we're going to be working side by side with the medical providers, say, hey, these are the patients that I noticed that are on your schedule today. Here are the patients of those that I would like to make sure that I have a visit with today as well. And then what could happen is that in some of those introductions where I'm going to spend, 15 to 16 to 20-ish minutes with the patient, if that patient needs additional services, then I can bring them back on my schedule and visit with them at a later date without the medical provider. We call that a warm handoff, where we're really working together, both the medical and behavioral, where the patient's going to see both the medical and behavioral health clinician at the same visit. Often we provide support for mental health concerns, depression, anxiety, substance use disorders, ADHD, bipolar disorder, the list goes on, as well as physical health concerns, which is not something that many of us receive the training in our graduate programs, but really it's learning on the job more about diabetes, how the stress of managing diabetes is going to be affecting their blood sugars, chronic pain, hypertension, sleep issues, among a myriad of other medical conditions that have a behavioral health component attached to them. A central goal of the integrated behavioral health model is to improve access to behavioral health care while supporting the interventions of the medical team. Now, what's really so fun about this is recognizing that this is how we can help change the stigma. There's never any stigma when you say, oh yeah, I had a doctor's visit. Well, guess what? We are in a doctor's office. And so it's really trying to help merge and change that stigma to say, yeah, we all need that support. If there's anything that we've learned from the pandemic, it's that it's okay to need help. So here at our facility specifically, we have 14 medical providers, both DOs, MDs, family nurse practitioners, and physician assistants. And then we have 7 behavioral health providers. A couple of us are LMFTs. We have some LAMFTs, CMHCs, LCSWs, and CSWs. Rather than use each of those licenses, it's just easier to call ourselves behavioral health consultants, recognizing that our priority is the behavioral health needs of all of the patients that do come in. It's really great to work side by side. Really, you can see that ratio of there's 7 of us and 14 medical providers. Talking with some of our medical staff, they're like, oh yeah, I would never work anywhere that doesn't have that behavioral health support because of the positive impacts that they've seen with their patients, which we will get into shortly. This is our healthcare team. So first and foremost, we have Lori Wright, who is our CEO. And I would say that she is definitely the driving force for the integrated behavioral health approach. When she hired me on in 2017, I was one of 2 BHCs, and now you can see there are 7 of us. We have now hired 3 interns and are also hiring 1 more full-time clinician. So you can see we have Talasia Bracken, she's up in Cedar City, Adam Monk down here in St. George, Kenzie, Galia, Stephen Lorraine also here in St. George, and then I am the director, so I oversee all of them. So Lori and I often meet shoulder to shoulder to say, okay, how can we overcome these barriers to integrating behavioral health care in a medical setting, because it is so new, not only for all of the behavioral health staff members, but also for the medical staff, as well as the support services that we have. Definitely the core of IBH is team-based care that provides care management and supports individuals in their health goals, be that medical or behavioral. Working closely with primary care providers, the BHC delivers brief, evidence-based services to patients using the integrated behavioral health model. So let's talk about some numbers. So you can see in 2017, when I was hired, the number of patients that we were seeing was pretty small. Now, let me be clear, these are specific to behavioral health. So as a system, we're in the 15,000 to 16,000 patients per year. But for behavioral health specifically, you can see that we were impacting very few lives in 2017, and then you can see the progress since then. So we have a 49.7% average year-over-year growth. So really great to see that not only are we becoming more reputable in the community to recognize this is part of what we do and how we do it, this is our mission, but also recognizing that the growth is sufficient enough to say we need more staff. Now, here are our encounters. So this last one, these are the patients. So it's, just over 4,000 patients in 2021 and just over 3,500 in 2022. And so these are the encounters. So obviously it's the same patient, but they're coming back several times. So in 2022, you can see that we had over 9,000 visits across the behavioral health system in that entire year in 2022. So that's a 32.9% average year-over-year growth, meaning we have more patients that are coming back year by year, which is really excited to see because they know, listen, we are here and we introduce our services in an integrated visit, not necessarily saying that you need to come visit with a therapist, right? Quote unquote therapist, but hey, anytime you come see your medical provider, I'm going to step in and I'm just going to touch base with you. Patients that have diabetes that might be okay controlled, they're coming in every 3 months. You can bet I'm going to step in. Hey, how are you managing your diabetes? How are you working on your diet, on your exercise? Any concerns about your insulin use? I'm really trying to make sure that we are merging that need. So that way, when the need does arise from that patient, they already know, oh, I remember I could go visit with my medical provider and I can see a BHC at the same time to talk about this family stress that I've noticed is increasing the complications with my diabetes. With each of those BHCs, what we do is we have 60% of our schedules is what we call integrated, meaning we are shoulder to shoulder with those medical providers, what's the word I want to use? Scrubbing our electronic health record to say, hey, these are the key patients that I really want to make sure that I visit with. And then 40% is specialty, where we have patients come back specifically just to see me, where we can spend a little bit more time together, either doing some trauma work, maybe just some cognitive behavioral therapy, some parent-child interaction therapy if they're young kiddos with some behavioral concerns, among other evidence-based approaches to that care. So here was our most recent picture of all of our medical and behavioral staff members. Our mission is to make lives better in Southwest Utah by providing access to quality healthcare, regardless of financial, language, and cultural barriers. And I would definitely say that this is exciting to be part of this team, to say this is exactly what we're doing. We are making we are decreasing those barriers and increasing that quality healthcare regardless of barriers. So let's talk about how integrated behavioral health impacts couples. The reason you might be asking about that is because as a licensed marriage and family therapist, obviously this is what I really love doing. And so what you can see here is that 60 couples received therapy in 2022. So what that means is that 16 couples had their first therapy session integrated with medical services, meaning one or both of the partners was coming in to have a medical visit of some kind, and the need was brought up for some type of marital issue, and then a BHC would go in and then would offer their services at that point. And then you can see 6 couples had their first therapy session within a week after the medical services. So really just kind of trying to merge that gap between medical and behavioral, saying we can see you at the same time as often as possible, and then obviously we always can have other visits to get you in. Every day we have same day appointments and we have walk-ins, and that's just part of what we do, is recognizing that I don't want to say that we are a crisis facility, because we're not. That's what the emergency department is for, but definitely we want to take care of our patients. And so if one of our patients is going through a crisis, say, hey, I need to get in today, 9 times out of 10, or even more than that, I'm going to say, absolutely. You get them in, they're going to see their medical provider, and then a BHC is going to go in, and we're going to really kind of connect our services at that same time. How is integrated behavioral health effective? So what you can see here is the BHC is first going to meet the patient in the exam room. And what that does is that then brings it into the patient pool. So the patient, if they need to, they can start to see the therapist for brief therapy, which is then we'll move them to our specialty therapy, where we'll say, hey, let's visit with you for 8 to 12 sessions, see how that goes. And then, of course, we're going to return you back to our patient pool, where I can do 60-minute follow-up visits with you every time you come see your medical provider, every time. And then, you know what, say 6, 12, 18 months down the road, there's another life-altering event that you need a little bit more specialty therapy, guess what? We're going to bring you back in. We really want to house all of our patients here, saying we can be your lifelong facility, not only for medical, but also for behavioral health. And then, of course, if there is some symptomology that's greater than our line of work, then we're also going to refer to our partnering clinicians in the agency to say, hey, you might benefit from weekly therapy that's 50 minutes instead of what we do for 30, just because we know that that can be more beneficial for you. Now, I use these numbers loosely because we don't have a hard cap on sessions. We recognize that the need is there. And so if patients have a need, we want to definitely do our best to meet that need. So I want to talk a little bit about some of these numbers. So what you can see here is that the PHQ-2 is a 2-question survey derived from the PHQ-9. And you can see that in 2022, there were 38,000 screenings completed on 12,799 different patients. Why? Because we believe that a PHQ-2 is important enough to ask it at every single appointment. So it doesn't matter your age, it doesn't matter your sexual orientation, your gender identity, your sex, it doesn't matter your income. You are always going to be asked 2 questions derived from the patient health questionnaire at every single medical appointment. If that is a positive screen, then you're going to receive a PHQ-9. And what that's going to also trigger is it's going to trigger a visit from one of our behavioral health consultants. Now, often I won't go in if it's a negative PHQ-2 score, but sometimes our medical assistants and providers can say, hey, I know this, you said no to this and this, but you have these other health concerns that are indicative that there might be more of an issue. And so recognizing that a BHC at that point will then come in to help kind of support the medical provider in those interventions. What we're noticing with those PHQ-9 scores is that the average PHQ-9 score reduction is that there is a 7.9 reduction if they, 7.6 reduction if they only see their medical provider. So say they're coming to see their medical provider, they want to get on some type of antidepressant, which is just fine. If they only are seeing their medical provider, there's only a 7.6 score reduction in the PHQ-9. However, look at this statistic, 37.2% greater PHQ-9 reduction if they are also seeing an IBH. So that just, I mean, I feel like that's a huge key indicator here that if you want to have a decrease in your PHQ-9 score, yes, medicine helps, but medicine coupled with therapy, meaning seeing a BHC at your medical appointment, is going to have a greater reduction of your PHQ-9 score, 37.2%. So that's been a really helpful statistic for us to share with our medical providers as well, because then they are more prone to say, hey, I need a BHC because this patient just scored X score on the PHQ-9, and we really want to help tackle this before it becomes a much larger issue. The GAD-7 for anxiety, we've done 1,300 screenings with 1,000 different patients. That one is not as common, but often if the PHQ-9 is positive, a lot of our handouts have the PHQ-9 on one side and the GAD-7 on the other. So it's just another tool that we use to measure and help screen and diagnose for depression and anxiety if needed. Now I want to go into a little bit more detail by the diagnosis. Depression and anxiety, of course, along with trauma, we've all received that training. And so that's really exciting to have that training. But then hypertension and diabetes, I mean, come on, really, as mental health clinicians, we really don't think about the impacts that they have. But I think that's where I love my career choice as a licensed marriage and family therapist, is that I was trained on the ability to kind of bridge these gaps and look at the whole system, right? So if one patient comes in, I'm like, well, let's bring in some family members, because it's not just you that's having the issue, but it's a whole system approach. And I think that marries well with this setting, because it's also recognizing, well, yeah, you might have depression, but also you've got diabetes. So we really need to be able to bring in that diabetes piece and that depression piece and talk about it at the same time, to make sure that we are adequately treating you and all of you without missing any important parts. Okay, so let me just share some numbers about depression. So in 2022 alone, there have been 31,731 depression screenings. So our behavioral health providers often utilize a follow-up encounter. And since 2020, patients who scored a PHQ-9 of 9 or greater received a reduction at 7.6. So it's going back to this score of how amazing those reductions have been. For anxiety, there has been a 588, 997, and 1120 in 2020, 2019, 2020, and 2021, with the 2022 numbers you see right there. So what we're noticing is that the follow-up we've done since 2020, patients who have scored 10 or higher on the GAD-7 experience an average decrease of 3.5 points, which translates to a reduction in 19.7%. So it's same with the PHQ-9. What we're noticing is, yeah, if the patient's coming in because they have anxiety and they want medicine for it, great. Yes, we want to support that. But there is a 19.7% greater reduction if they also visit with a behavioral health consultant on that same day. And then obviously patients who receive anxiety screenings have an average of 3 encounters with a behavioral health provider, regardless of their score. So that's when we're saying, hey, you got pretty severe anxiety. I know you're going to start taking medication. Great, let's keep taking it. I want to see you every week for the next 3 weeks until your medication has kicked in even more. And we're going to focus on some coping skills before we get to that therapeutic dosing of that medication. I want to bring up trauma. So in 2021, we began doing some screening for adverse childhood experiences. A total of 1,114 patients have received this. Now, I'm careful to kind of clarify with this trauma screener, we don't do it in one of those brief 15 to 16 minute sessions. They're not even called sessions, visits, because of the severity of those questions. And I don't want to ask the question and then not also have time to kind of process through what it's brought up for the patient. And so that's why that number is a little bit lower. So just over 1,100 patients have received that. And that's because we're going to ask that question more in our specialty sessions, where we say, hey, I want to ask this to make sure I'm getting an accurate picture of what you've been going through, and see how we can help in a more concise way. Let me just look. I think I see some chats. Let me pull this up. Okay, I know FHC used to run behavioral health support groups. Anything currently? If not, were there barriers used to run? Okay, no, great question, Lisa. So yeah, we did have some support groups pre-pandemic, and they were really helpful. What we would do is we would kind of target certain diagnoses and say, okay, this is a group, support group for those with diabetes over 9. Your doctor is going to prescribe it, quote unquote, in conjunction with your medicine, as a way to say, how can we help you with that? Yes, they were helpful. No, we were not currently doing any. It seems like just the pandemic really kind of uprooted all of that, saying, okay, we don't need to do that as often. I would say some of the barriers to continuing were also that more agencies in the community started to offer support groups as well. So initially we were doing a lot of support groups every night of the week. We would have medication assisted treatment support group. We had a diabetes support group. We had a coping skills support group. And so they were super helpful. But then what we noticed is that more places in the community had more staffing than we did. And so they started to do more support groups. And so we thought, well, if we want to support these other agencies in the groups that they are doing, and we'll do our best to kind of support the patients that come in and offer that as best we can. Hopefully that answers your question, Lisa, but I would say the main barrier is, I guess, staffing shortages. I have some interns that are excited about it. I said, let's do it. Let's totally do it. So I'm sure we'll be starting some soon. Okay, so with the trauma, what I would say is that we are also focusing on trauma with children. So yeah, we've screened just over 1,100 adults, but we also are doing more childhood pediatric screenings, and we've done 284 of those, as 2 of our clinicians have been trained in the evidence-based approach of PCIT, which stands for Parent-Child Interaction Therapy. So it's really kind of exciting because what you're doing in PCIT is you have the parent and the child in the therapy room, and then we have a one-way mirror, and then the therapist, and if it's a couple that's together, then the other partner will be back with the therapist, and the therapist is kind of coaching the parent how to help with certain behaviors for the child. So it's kind of really exciting to have the parent watch, and then the parents will swap. So that way it's really kind of drilling in the idea of how we can kind of connect these parents with the resources to know how to help that behavior at home. I used to do a lot of play therapy. That used to be what I was in private practice for, and I loved it. But I also realized the child was then going home and there was no major change. And so this is kind of a lot of fun because it's helping elicit the parent to do a little more of the change and how impactful that's been. In fact, one of my couples said, one of my families really said, I cannot believe how helpful this has been. So it's been really cool because the kiddo was coming in, having these huge tantrums where there was like getting physically aggressive, breaking toys, throwing toys. And so just kind of being able to kind of, I'm going to use the word loosely, coach. So I kind of coach the parent how to respond, and then obviously kind of give positive feedback when we see behavior that we want to see more of. And it's really kind of exciting to watch the parent like have that little light bulb go off and be like, oh my gosh, I cannot believe I just had that positive experience with this. Now I feel empowered to do this at home. And so it's kind of really fun to do that with trauma as well. Let's see, let's talk briefly about diabetes. So we received a grant. It's the UPIP BHC, UPIVIC is what we call it. So before we got this grant, what you'll see is your standard bell curve. And so 45% of our A1C results were in the first 2 quintiles, meaning the average, you can see right here, not necessarily the average, but it was at 9. The top of the bell curve was at 9. And so what you can see is that it was your standard score, which realized we need to assert a little bit more intervention to try to help these patients out. So what happened is that we started to have our BHCs go into every exam room where the patient had an A1C above 9. And we would just start to talk about stress. Say, help me understand like how often you're thinking about your A1C, how often you're thinking about diabetes, how much it's impacting what you're eating throughout the day, your stress levels. And we realized pretty quickly, it increases the stress a lot. And so we started to kind of really dial into these patients that were coming in because they had diabetes. And after a couple of years of doing the specific intervention, you can see that 61.8% of the A1C results were in the first 2 quintiles, meaning we were able to help push that A1C down to 8. And so it's kind of really exciting to see how it shifted. You can see how that bell curve shifted, that your number of patients with an A1C above 9 is much smaller than it used to be prior to those interventions. Now, keep in mind, this is both medical and behavioral, and we recognize that changing a number like an A1C comes very slowly. For those that don't know, an A1C is a snapshot of your blood sugars over the past 3 months. And so, yeah, you'll have your daily dose of blood sugar testing for those with diabetes. But then sometimes at the medical clinic, what we do is we do an A1C check to say, okay, this is what your numbers look like on your side as you're doing your daily dosing or you're checking daily. We want to check for over the past 3 months, which is a greater predictor where there's less volatility. And so to see that progress really is exciting to see how much of a change there has been for these patients with diabetes. And then lastly, what I want to talk about is about hypertension. So what we're trying to do is we are continuing expanding integrated behavioral health into our services, and our most recent focus has been for hypertensive patients. Now, when I think of hypertension, I don't know, I could ask what you guys think about hypertension. Uh, Feel free to chime in if you want to, but essentially hypertension is just your blood pressure, right? How fast is your heart rate beating? A lot of patients will come in and they'll say, oh yeah, it's just white coat syndrome, which they joke is saying, I always get nervous coming into the doctor's office. Well, it's fun because yeah, let's joke about it that way, but also let's take it to the next step and say, well, let's teach you some ideas of how we can decrease your blood pressure, meaning let's take control of your breath and see how that can affect the way that you breathe. And so what we notice is that 60% of the behavioral health counters were integrated with medical services in 2022. And then we have seen an average of 37.6% year-over-year growth since 2012, including with our hypertensive patients. So let me give you just kind of a brief synopsis of what a breathing skill I might do with a patient with diabetes. So feel free to close your eyes or soften your gaze if you'd like, and bring your attention to your breath, noticing the inhale, noticing the exhale, in through your nose, out through your mouth. What I want you to do is I want you to take your right hand and put it on your chest. I want you to take your left hand and put it on your stomach. As you breathe, I want you to notice which hand is moving more. Chest or the hand on your stomach. Now, the name of this exercise is called belly breathing. So as you guessed, the hope is that we can push your breath from your chest to your belly. Now, this skill comes from trauma-focused cognitive behavioral therapy, but I find it to be so helpful that I use it in a lot of other areas as well. So what we're going to do is we're going to take a couple deep breaths together, and I want you to keep the hand on your chest as still as possible. And I want you to really use your hand on your belly to kind of bring out your belly and then push it in as you're inhaling and exhaling. Breathing in through the nose and exhaling through the mouth. In through the nose. In through the nose. Through the mouth. Always a question, what are you noticing now? Can you tell a difference between when you were breathing before we started this exercise and now that we're breathing after? Because the hope is that, of course, we can breathe more from our belly and less from our chest. Noticing that anytime you notice that maybe your blood pressure is a little bit high, maybe you're feeling symptoms of anxiety, then for sure we want to put your hands on your belly and your chest, just as a simple reminder of this is how you can breathe a little bit more calmly. So that's what I often will do with my patients with hypertension, just to say, this is what I want you to practice a little bit more often. And if you have a way to check your blood pressure at home, please do and let us know, because we would love to kind of cross-check that with the results that we're getting in the office to see if in fact you do have white coat syndrome or not. What I want to do is, this is kind of the summary and questions. So what is IBH? How does IBH impact couples, and how is it effective? But before I get into any questions, is I want to kind of share a couple of stories with you that are kind of exciting. So I was invited to do a warm handoff a couple years ago for an individual patient who was coming into the clinic for panic attacks. And so these panic attacks were so frequent and so distressing that the medical provider said, hey, let's have a BHC just come in and see how they might be able to help. So it was discovered that the symptoms started after an affair was exposed. Guess where that couple ended up? If you said divorce court, you were wrong. They ended up visiting with me and now they're doing much better. And so it's kind of exciting to say, oh, okay, so these panic attacks don't just come from nothing. I mean, for some people, maybe they do, and we can approach that. But in this situation, it was a little bit more related to their relational dynamic. Another story that I think is super helpful is there was a kiddo who was coming in because he was being bullied at school, and this bullying, of course, is never a good thing. But they were coming in to talk to the medical provider about maybe some ADHD medications or something along those lines. And so the medical provider said, well, let me just have one of our BHCs kind of review this patient and see if what they think. Now, the reason that's so important is because ADHD and trauma have such a strong overlap that often it can get misdiagnosed. And so while the kiddo was coming in to receive treatments for ADHD, we realized, hey, actually there's some trauma here that we want to focus on. I don't want to say fixing because they're not broken, but we want to target our services on processing through this trauma. Processing, that's the word I want to use. Let's process through this trauma and increase that social support instead of treating the ADHD, and see how that goes. So we brought him in, we started doing PCIT, really helping empower the parents with a lot of these interactions so that way there was some better connections all around. And a lot of the symptoms of what we originally thought were ADHD started to decrease. And so it's kind of cool to not only see that empowering happen in the home, but also at school, just the self-confidence was improving, less bullying going on in general, and really exciting to kind of see that. And then the last one I'll share is that this patient had been working with his PCP for quite a while due to some pretty severe depression, but it was just kind of like stagnant, so it's just like, yeah, I'm depressed, but I get that this must be my normal. So this patient had gone through a divorce a couple years prior, and was not super thrilled in his living situation. So the medical provider said, hey, DJ, come on over. I'd love for you to visit with this patient, see if there's something you can do to kind of help him out. So we did some individual work for a while, talking through depression, giving some coping skills, processing through when it started, what was going on there. And during that same time, he had gone through, so he had been divorced for a couple of years, and he was going in and out of these relationships. He said, every relationship I have reminds me how much I miss my ex-wife. And so we were kind of processing through that a little bit. And it turns out that he and his ex-wife started to date again. And so that was kind of exciting to then bring in which would have been the ex-wife / girlfriend. And so they started to do some couples work together. And then we kind of started to do what we call premarital therapy. Like, all right, let's try this again, see if we can work at it that way. And in their words, they wanted to do it right this time. Several months after doing some couples therapy with lots of great improvements, they just got engaged on Christmas. So they'll be getting married later this year. So super fun to kind of have that interaction, whereas I don't know that they would have come to a medical setting had it not been for the introduction with their medical provider from the very beginning. What I'm going to do is I'm going to stop my screen share now and see if there are any questions that you guys might have. I think I see one in the chat. Okay, autism and stress, anxiety, and possible trauma. Yeah, so definitely that we do look for any autism, any stress and anxiety and possible trauma, and work at it from that perspective to see how we might be able to integrate our services, both the medical and behavioral side. And if it is, depending on the severity of autism, of course, connecting them with other agencies in the community that might have a little bit more expertise in that for sure. Any other questions from anybody that you can either unmute yourself and ask them, or you can put them in the chat. Definitely a different model of therapy, but what we're noticing is that it's definitely becoming the new standard of care. I know that there's a couple other facilities across the state of Utah, community health centers specifically, or federally qualified health centers that are trying to do more and more of this, which is exciting because we know that the need is there, right? Of these patients that I've talked about, many of them would never initially go in and seek therapy But because it's introduced in a medical setting, they're like, oh yeah, I could do a couple visits, just because we know of the need for it. Do you screen for substance abuse? We do, yeah, absolutely. So every single visit, the medical assistant asks about their alcohol use, as well as tobacco use and other illicit substances. And so depending on that, then BHC will go in and say, okay, let's talk about your KJ response. Tell me about your alcohol use. How severe is it? And then of course, always asking, how is it impacting your work life and your family life, and kind of going from there. So absolutely, we screen for substance use disorders. We also have a medication-assisted treatment program, which is to help patients who have some type of opioid use disorder, trying to get onto something that really is a little bit not as addictive, helps them process through and live your normal life. One of the patients, I'll share a success story here, is this patient was living in a travel trailer with no amenities, with his family, trying to really navigate life while still being thick in the addiction. Really had a hard time, and then after some incarcerations, was able to kind of decide, okay, I need to live a life in recovery. And so not only was this patient able to kind of get connected with more trauma and substance use treatment, but then decided, okay, I'm ready for long-term recovery. And so last I visited with him a couple of weeks ago, he said he's been in recovery for a solid 4 years. And in those 4 years, only one, I want to use the right term here, one incident of use, but still focusing on the long-term recovery. And so it's kind of exciting because now he's in a house with his wife and kiddos. And so it's really cool to kind of see he's got a full-time job. He's like, oh yeah, I get salary now. He's like, I never thought I'd have a salary paid position. I always thought I'd be hourly. And so it's really exciting to see how medication assisted treatment has been so beneficial, not only for him, but for his family. So hopefully that answers your question about substance use and how we can kind of impact that in the community. We also, because we have several of our physicians, our OBs, meaning every time a patient comes in and they're newly diagnosed with a pregnancy, can you be diagnosed with pregnancy, or they're disclosed that they're pregnant, we always include a BHC to those visits, because we know that can be traumatic, whether it's planned, whether it's unplanned, whether the support of the family or the other partner. And so we definitely want to go in, and then of course, not only on the first OB visit, but as needed throughout their pregnancy, and then post-delivery for sure, which is often being called the 4th trimester, is recognizing we want to make sure to know that these new parents have support, because it's stressful. It is stressful. Okay, another question. What is your follow-up process with patients after treatment? Are there ongoing follow-up needs? Tell me more specifically what you mean about treatment. If you're referring to like our medication-assisted treatment program, the follow-up is monthly. Say come in once a month, either get your prescription or your injection. You'll see a BHC every month. We also want to encourage you to attend your support groups in the community, whether that's in AANA, if you're part of USARA or other type of facility that might have the treatment. But for sure, like we will be your home forever. Especially with our MAT services, we don't always say, we only want to keep you on this for a certain period of time. I would say originally that was our mentality, but then we realized that anytime that was happening, and with the growing field of research, is that there are no real negative side effects for some MAT medications. Just because it's like, why, the one story I just shared is this gentleman was like, I tried to come off of it, but then I realized the urges were so severe that it wasn't worth trying to decrease my MAT support. And so he's like, I'm okay being on this medication, at least for the foreseeable future, because it keeps all of the triggers at bay. I have my salary paid position. It's like, it's just not worth it to try to decrease it, have an increase, and then have a relapse or an incident of use, which is really nowhere near where I want to be anymore in my life. Perfect. Okay. Yeah, that's what I was assuming you were asking. Great question. Any other questions I can answer? Okay, Jason says, with your setup, are you able to do direct admission to inpatient behavioral health units? Great question. We have a psychiatric mental health nurse practitioner on staff, and she can. So with our BHCs, what we do is if it is that level of severity, then for sure we're going to consult our psychiatric mental health nurse practitioner to have her kind of help triage that patient. But we're primary care. And so often if there is somebody who needs inpatient behavioral health, rarely are they going to primary care. Often we talk about the Access Center, at least down here in Southern Utah, the Access Center at Intermountain, where they can go and just kind of have their safe spot for a couple of hours. And then after that, they can decide if they need to go into the behavioral medicine inpatient unit or not. Which I always suggest having a psychiatric mental health nurse practitioner on staff, because not only do they understand the model of therapy, but they also understand the medical side. And so just having somebody like that on staff to kind of bridge those gaps is super helpful as well. Now, all of what I'm sharing is essentially Family Healthcare's model of how we're trying to do things here in Southern Utah. Is it applicable to everybody? No. It's going to be different for everywhere, every location, every facility, but this is kind of what we have found to be super effective, not only for rates of reimbursement, but the interventions for the patients, and how receptive they are. This is just our model of care. Initially, people are like, why are you in here? Like as a therapist, with our spiel, but I'm like, no, really, I'm just here to help kind of support your medical needs. And we want to make sure that we're helping you with your overall health. And I think that's been super appreciative with a lot of patients, recognizing the positive impacts of what we're able to offer at such an affordable cost. Any other questions I can answer? Lisa, I'm glad you enjoyed it. Well, if there's no other questions, I'll screen share my last page again. If anyone wants to get a hold of me, this is how you can do that. This is my cell phone or my email, or it's davidz@familyhc.org. Happy to kind of answer questions as they come up. I know that it's sometimes it's hard to ask those questions, and so I can kind of be a point of contact to answer questions that come up for what we're doing. Trying to say, like, you know what, in a perfect world, I would say my 5-year goal would say to have a federally qualified health center or something similar with as many behavioral health as we have in the community, because we know that the community needs it. And this is just a great way to offer that support to our community. You are welcome. Thanks everyone for your kind comments. Hope you enjoyed. Reach out if you have any questions.
All right, and while everyone's signing off, I just want to thank DJ for his time and the preparation that he put into this presentation. This was awesome. I think it answered a lot of questions and it answered a lot of mine. I'm going to drop in the chat here the evaluation form that you will all need and the code that you will need as well. So go ahead and access that. If you're unable to click on this link for some reason, go ahead and shoot me an email. I'm happy to send it to an email. I believe a lot of email addresses that are linked to Intermountain Health might be having issues with a firewall setting that prevents them clicking on Google Documents. And that's okay. I can work around that. If you want to shoot me an alternate email, I can send it to that. That works for you. But you will need the code IBH221 when you fill out that evaluation. And so this will allow me to verify your attendance for anyone who wants CE credit. I'll be sending out a certificate, hopefully the end of this week. And as always, if I ever miss you, like let's say you're like, oh, I couldn't complete the evaluation, in that first week, I did it, the following Monday or something. That's okay too. Just go ahead and shoot me an email so that I'm aware that you still need to receive your certificate. Because usually what I do is I'll send them all out in a blanket email. Whoever's answered the evaluation, I'll send them out together. But on occasion we run into a few issues. Maybe someone didn't get the email or their server blocked it or something like that. Just go ahead and reach out. I'm always happy to send a separate email to you. But yeah, go ahead and do that. And I'll also drop a link to our YouTube channel for anyone who might want to review this at a later point in time. Give me a couple days to upload that, but here's a link to our YouTube. You can find other CE courses on that as well, past classes that we've covered. So go ahead and take a look at those. If you want to review something that you already attended, go ahead and do that there. That's what it's for. And if you have any other additional questions, please feel free to email me. Again, I want to thank DJ for his time, and I don't know, were there any other additional questions that anyone had for DJ before we let him go?
I do. This is Cindy Law. I was wondering, where did you say that we could get more CEU classes and watch them?
So I dropped in a link to our YouTube channel.
Oh, okay.
Yeah,
I see it now.
It's in the chat. You can view those there. Now, unfortunately, you can't receive CE credit for those classes because you do have to have been in attendance at the time that they were held. But for example, this one, definitely would count. But sometimes people reach out to me and they say, hey, I know we covered this topic, a month ago. Where can I watch that class again? This YouTube channel is excellent for that. If you want to go back and, catch up on what was being said. I know I'm a huge note taker. I take copious notes all the time. And sometimes these classes go so quickly that I don't have time to write everything down. Or, like in DJ's case, he's got a lot of great slides here and I might not be able to jot everything down. So the YouTube channel is great for that. You can kind of go back and scrub through the video to the slide that you need. And it's got a lot of great information there. Should you run into an issue like that. That's a great question. Any other questions for DJ before he signs off? All right. Well, thank you, DJ. It's been a pleasure. I found this class, very educational, answered a lot of questions, and I think I look differently at IBH now. Now that I know a little more about what it is and how it can benefit all of us. So, thank you for your time.
You're welcome. Thanks for hosting. Hope it was helpful. You guys all take care.
All right, see everyone. I'll probably leave this up just a little bit in case anyone has any additional, questions or anything that they want to address. I'll leave the chat up just for a couple more minutes before we sign off.